All right, any questions on aortic dissection? All right, we got 20 minutes. We got 20 minutes to cover this. This is not about the routine aortic dissection. This is about the atypical aortic dissection, so that you don't miss it. Because when you do, the outcomes generally are not good. So there's the big three: the acute coronary syndrome, the pulmonary embolism, and the aortic dissection. Those are the three chest killers. And I wanted to kind of start out with this idea about the aortic dissection without pain. Yes, that can occur, even though the classical is that this tearing pain and all this other stuff. There is a subset of patients, something in the neighborhood of 10% of the patients have no pain. Probably the classic case was John Ritter. Remember John Ritter? He was on, his father was Tex Ritter, which is black and white movie cowboy kind of guy. John Ritter was on these sitcoms. He was at NBC Studios in Burbank, beautiful downtown Burbank, doing a show. Became quite ill, but it was quite nondescript. He felt terribly, turned gray, no chest pain. His friend Arthur Fonzarelli, who is that? Arthur Fonzarelli is the Fonz, yeah. Henry Winkler took him across the street to St. Joseph's Hospital, which is literally across the street, and he died there. And there was a big lawsuit. The hospital settled because of his potential lost income. They sued a cardiologist there. That doctor won, and they sued a radiologist. And the radiologist was not. It was not contemporaneously. They had done a CAT scan of this guy, which showed some aortic calcification kind of thing, which they alleged should have been told to Mr. Ritter, et cetera, and whether it was or were not was an issue. But anyway, the radiologist got out. The hospital, they had a problem because there was a delay in getting a chest x-ray. That was kind of one of the issues. Whether it was the only issue or not, we'll talk about that. But one of the things is about these x-rays. So anyway, John Ritter is the poster child for the painless aortic dissection. So number one article, painless dissection. Number two, painless dissection. Some of the things that we need to point out here is that the subset has a painless dissection. Also, between 20 and 40% of people who have aortic dissections have neurologic symptoms. They look like strokes. So the type A dissection begins at the root of the aorta, goes up to the arch, goes up the neck arteries, and the next thing you know, this person is having what appears to be a stroke. Painless, looks like a stroke, better get that TPA out and go quick and kill them, because that's what will happen. There's a nice paper we did in the American Journal of Emergency Medicine in June of this past year. Patient had left hemiparesis and dysarthria, motor speech issues, and shock. Stroke with a shock kind of thing, what was it? Type A dissection. CT of the head is always going to be normal in those cases, so they qualify for TPA. So the idea here is this is a terrible combination. Painless dissection associated with neurologic deficits. And neurologic deficits could be in the brain, they could be in the periphery, they can be in the extremities, they can come and go, they can be in variable locations. They're not going to be the classic middle cerebral artery stroke. There's going to be something a little different about this stroke that makes you think maybe this is the result of a dissection causing this problem. So the theory here is basically, if that's going on, you're supposed to put as many things into your database that is consistent with stroke. So are you feeling the pulses? Are there any pulse deficits? Have I looked at the x-ray? Is there any widening of the mediastinum? Is there a left pleural fusion? Is there a movement of the left main stem bronchus to the right? Is the listen to the heart. Do I hear an aortic regurgitant murmur? Because the aorta is basically right there at the base of where the heart comes into the aorta. That begins, and so you can get a regurgitant murmur. You can get, instead of so the left ventricle pushes out blood, comes right back. Pushes out blood, comes right back. So the left ventricle is basically loaded with the blood, backs up to the left side, and next thing you know, you have flash pulmonary edema because of this new aortic regurgitant murmur, which is heard in 20 to 30% of cases. If you don't think to look for it, you may not find it, kind of thing. So that's one of the things you're looking in to make as many elements that are likely to be positive for what is else going on. But the problem is that many of these findings are inconsistent. Like, the majority of patients who have dissection do not have pulses that are unequal. The age of these patients, the literature is basically saying these people are around 60. They're not 70, 80, 90 years old in general, although there are some cases out that far. But basically, we're talking about 60-year-olds, and that's a number that comes up repetitively. So it's not like, oh, these people, 60 is not that old. I wish it was 60. The role of exertion, well, as you might anticipate, exertion has something to do with it. There is a study there, number 3, 90 dissections. They asked these people who were able to give some history. A quarter of them said, yes, strenuous activity. Like, they're talking about shoveling snow, playing racquetball, lifting heavy machinery. I like this one, vigorous sexual activity. That must have been pretty vigorous to blow your O-ring in that process. But anyway, that was according. And 40% severe emotional upset. Cancer, financial loss, divorce, those kinds of things were considered to be precipitants. Basically, we're talking about a nice surge in blood pressure to help move this dissection along. How good are the classic findings of aortic dissection? The whole point is they're not. Number 4, aortic dissection. This is focusing on missteps. Symptoms in varying locations, they say, and severity, can be transient, can go down into the abdomen. Arterial obstruction can cause end-organ manifestations. Like the brain, the stroke thing is an end-organ manifestation of some problem with the flow. Coronary arteries come off of the aortic root. Those things could be blocked up and give you ischemic chest pain, or at least in an EKG that it looks like it's ischemic, because that is a manifestation of the heart not getting adequate blood due to this mechanical event, this dissection of the aorta. There's these A's and B's. The A's are the ones that come right off the root of the aorta and go up to the arch. That's the A. That's Stanford A. And B is the one that goes down the back. And interestingly enough, the Stanford A's usually have anterior chest pain, as you might anticipate. The B's are the ones that go between the shoulder blades and the shearing kind of thing. Those are the distinction a little bit there. Genetic predisposition, we'll talk about that. 10% of the patients have no X-ray changes, which is a bad problem because 90% do, and so you've got bad luck if you're one of the small subset where, in fact, you're looking at that chest X-ray and you don't get a tip-off. Type A's get surgery, type B's get medicine. Surgery for aortic dissection. You know that guy, Michael DeBakey? He's a heart surgeon in Texas. He died, but at the age of 94, he had an aortic dissection. He invented it and decided to use it. But he refused surgery. And all of his residents around him said, what do you mean? What do you mean? You got to have surgery. And he refused it. They took it to an ethics panel right then and there, and they said, do the surgery. And so they did the surgery, and he was in the hospital 7 months, and he lived to see the opening of the DeBakey Center there when he died at age 99. So he lived 2 or 3 years after having his dissection. He has to be among the oldest people ever to have a dissection, but that was Michael DeBakey. Who else had a dissection, died of it, who is well known from around here? Lucy, you got some splaining to do. Lucille Ball died of aortic dissection. Let's see. Here's one. This is a review of 21 articles involving 2,000 people and their aortic dissections, and this is looking for things that make you miss the diagnosis. So they said most had severe pain of quick onset, but the classic findings that you're going to be looking for were present in less than half the cases in this chart review. So they say combinations, but here's the 3 most telling kind of things that you'd be looking for. Aortic pain, the classic aortic pain. Odds ratio, if you had that, 6.4. Mediastinal aortic widening on chest x-ray. If you see that, odds ratio is 58 times greater if you see that. Differential pulse of blood pressure, that'd be great too. The fact of the matter is that all of those are not universally present, and in this study, 7% of the aortic dissections had none of those things. And so those are the whole idea here is you can pick this up, but if you have a broader idea of what to expect. Peripheral pulses in study number 7, only present in 30% of the cases. There are 2 registry papers there. The International Registry of Aortic Dissection, which is 8. This is everybody puts their data in there trying to find out if we can find some things that are in common. What they find in common, mean age 63. The Bakey was 97, but the mean age is 63. And just remember that. They're younger old people. Age range, 17 to 94. 17, yes, because we're going to talk about the genetic predisposition cases. Moderate male predominance, 65%. 83% are Caucasians in this thing. History of hypertension, 3/4 of them. Type A, the one off the root, most common, 62%. Chest pain was most common in type A. Back pain, most common in type B, as you might anticipate. Chest pain was severe in 90%. Let's hope that's the case. Syncope was not uncommon, 9%. Patient faints, you got the big 3, you have acute coronary syndrome, syncope, and that could be due to pulmonary embolism, big pulmonary embolism, that might cause syncope. Better get that D-dimer. D-dimer's positive, fainted, it looks like a PE to me, give them the heparin, dead. Because virtually every aortic dissection will have a positive D-dimer as well. And so syncope, it doesn't occur with acute coronary syndrome, so they're basically left generally with PE or a dissection. Both of them will have positive D-dimers. One may do good with heparin, one will be killed with heparin. About 80%, they said, had abnormal aortic diameters or contours on chest x-ray, pulse deficits. In this study analysis, only 15% had pulse deficits. The other one said 30%. The bottom line is it's in the minority of cases. In-hospital mortality, about 27%. They said basically the mortality of this thing, aortic anteriors, that needs the surgery, 1 to 2% per hour. The second IRAD paper is number 9, and this one focuses on ways where we missed the diagnosis. What were the common theories? Prior cardiac surgery. Prior cardiac surgery, you must have a heart problem kind of thing, and so we think heart. Mild or no pain or atypical pain. CHF, sudden CHF. Well, in this case, we're talking about CHF due to this sudden aortic valvular problem. So you take an X-ray, you see the fluffiness, but the heart size is normal. This is not a heart that has had months and months and months and months to dilate. This is a normal-sized heart with CHF, which makes you think that this is flash pulmonary edema. What is the cause of this? Yeah, it could also be an ischemic process causing that. EKG consistent with ischemia. That was one of the things that misled people, and a normal chest X-ray. 10 is a look at 236 cases. A third of them were painless. Now that's really a high number, but that's what they said. A quarter were initially unsuspected. A quarter of them. Does the aortic dissection tend to run in families? You bet. Number 12. 20% of patients will report the same condition in a first-degree relative. 20% of patients, same condition in a first-degree relative. And this paper gives a report of a dissection in a 19-year-old. It's considered an autosomal dominant. Some animals have a predisposition to have aortic dissection. Anybody? This is for extra credit. That's right, turkey. Turkeys basically, and you can envision around early Thanksgiving, early November. There's probably a lot of stress in the turkey house, and the pressure's going up, and the opportunity for dissection, that pulsatile, all that stuff that they need. They should probably put beta blockers in the waters. In the beginning of November, everybody gets a beta blocker. We want you to plump up as much as you can. We don't want you to have any kind of dissection in advance here. Dan Sullivan, I don't know if you know Dan. He's the kind of like one of the medical legal gurus. He presented at ASAP a couple of years ago a case in which a teenager was being presented to the emergency department. He went with his mother and was having this chest pain and did an EKG. Didn't really find very much. They kind of wanted to poo-poo it, make it musculoskeletal, even though there was no evidence that it was musculoskeletal. It had to be because it was a kid, and they don't have heart troubles. And the mother mentioned about the family history of aortic dissection. They, oh yeah, sure, okay, fine. They sent him out, and then he comes back, and the same symptoms over and over again. She mentions again, there's a family history of aortic dissection. Yeah, okay, sure. And that's what he had. He had aortic dissection. And the point that Dan was making is this idea of anchoring bias. Anchoring bias is basically 19-year-olds don't have dissections. You've got to have something else. So I'm just going to screen out everything that doesn't agree with my bias. And my bias is that you have some kind of mechanical problem causing your chest pain because you're too young for coronary disease. And so this idea of anchoring biases comes up over and over and over again, where you latch onto a diagnosis and pretty much want to not listen to anything that doesn't go along with that diagnosis. And yet it's acknowledged that by far the biggest problem in medicine that we have in terms of risk management issues is not cutting off the wrong leg or doing its surgery, or I didn't take my time out, or I didn't make a mark on this leg and cut off that wrong leg kind of thing. It's about diagnostic errors related to delays in diagnosis and cancers that are, kind of everybody overlooked the fact that there's a cancer. There's a whole litany of things that basically say diagnostic delay is really where we are falling down, and we have no systematic means of reporting diagnostic errors because it involves individual physicians. They don't want to bring it up. And so, they're talking about all these great things about patient safety, and there's this one huge secret. It's called diagnostic error that we just don't want to talk about. Anyway, the paper I like here, I love 13. Now, it's got to do with abdominal aneurysms, but dig this title. The lifetime prevalence of abdominal aortic aneurysms among siblings of aneurysm patients is 8-fold higher than among siblings of spouses. An analysis of 187 aneurysmal families in Nova Scotia, Canada. There's no point in reading the paper. This guy gave the entire thing right in the title. This paper basically also says that these things run in families. An ultrasound was positive in 6% of SIBs, 11% of the males, and 3% of the ladies of patients who had first-degree family members who had aortic aneurysms. Lifetime prevalence was very high. As a matter of fact, doing ultrasound of the abdomen in male smokers, looking for aneurysms, is much more productive than doing mammograms on the entire world in terms of the yield. The yield is much higher. It's not something that most people really think very much about, but because of this genetic predisposition, and it's a male preference and smoker preference kind of thing, that it is a high yield kind of thing to do for screening. What's the preferred imaging? These papers talk about making mistakes with chest x-rays. So the paper number 14, the sensitivity of plain chest x-rays was 64%. It missed a third of the cases. Now, the A's are harder to diagnose in chest x-rays than the B's. That's what that says. 15 says we missed 20% on chest x-rays. 16 basically is 2 radiologists looking for 7 specific findings associated with aortic dissection, and the sensitivity of these 2 radiologists was 64%. They missed a third of them. Therefore, we're really talking about CTs. Yes, if you get lucky, you take the x-ray, 80% should show something traditionally, but the fact of the matter is it could be substantially less than that. So CTs are where it's at. And 19 to 22 talk about the triple CT. This is the CT that looks for coronary artery disease, pulmonary embolism, and dissection. Has anybody in this room ordered a triple CT? Not one. So we're not going to talk about this. Actually, these papers all said, this is cool, this is going to be the wave of the future, we're all going to be doing this. And when you look at the year of these papers are, years ago. Nobody's doing it. And there are some technical issues. There's lots of radiation, about 25 millisieverts, which is 10 millisieverts is 500 chest x-rays, so it's a bajillion chest x-rays. There's the issue of getting some breasts cancer in women who get these things. There's some issue of timing. You can get the coronary arteries and the aorta, but you don't do so good on the PEs kind of thing when these things are done. There's lots of contrast being given in these cases where there's the risk of contrast-induced nephropathy, etc. D-dimers. The long and short of the D-dimers is 95% at least will have a positive D-dimer in the process. You got this dissection through the wall, here's a big clot forming kind of thing. It would be the unusual case. Now those people who don't like lab tests, fortunately he's not here, would say, well, what is the confidence interval? The confidence interval may go down to 75%. But the fact of the matter is that is the worst. Why don't you look at the more positive point of view? Number 25, D-dimer, 99% sensitivity. Number 26, it's a review of 16 studies, 97% sensitivity. Number 27, 10 studies. In those 10 studies, 5 of the studies had 100% sensitivity. 2 of the studies had sensitivity between 98 and 99%. So clearly the preponderance of the literature says it would be the unusual case not to have a positive D-dimer. It's not the only, you wouldn't hang your hat on it because it was positive. You'd have to look at all of these other kinds of things as well, but you would certainly expect it to be. What about confusing this is an MI for a dissection? There's 3 great papers here. First one, 50 patients with dissection. Not one of them had ST elevation. And since none of them had ST elevation, none of them qualified for thrombolytic therapy. 50, not one had ST elevation. That's cool, makes you feel better. In that study, which is number 28, I think, the ratio of AMIs to dissection, there were 38 myocardial infarctions to every 1 dissection. Now, some people would say the ratio should be more than that, but that's kind of what they found in their study. With 29, here's another look at 609 patients who got thrombolytic therapy. 609 got thrombolytic therapy. They must have had ST elevation. Well, actually, how many of them really didn't have a myocardial infarction? About 6%. With that, and that number comes up over and over and over and over. That's the error rate in these thrombolytic papers. But in any case, that was 35 patients. How many of those 35 patients had aortic dissection? 1. So 1 out of 609 who had gotten thrombolytic therapy had an aortic dissection. 30 is 2 case reports of dissection, and acknowledging that in the GC and ACID trial, that somewhere between 4 and 6% of people who are thought to warrant thrombolytic therapy don't have MIs. So all of these papers would make you think, no sweat, except for paper number 31. Paper number 31 is 66 consecutive dissections. Elevated troponins, abnormal EKGs, normal chest x-rays, and lack of pulse deficits all confused the diagnosis. So of the 66 patients, 39% had initially incorrect diagnoses. That was 26 people. 21 of the 26 were thought to have acute coronary syndrome. So this is the one that says, no, not so fast, because elevated troponins, yes, abnormal EKG, yes, normal chest x-ray. This is all the bad things come together. This is all the overlapping circles of badness came together, and you're the doctor who missed this case. Treatment, no differences in treatment. The treatments are all the same. Basically, lower the blood pressure with nitroprusside, stop the force of contraction with some beta blocker. Nothing really particularly there. Labetalol, esmolol, titratable nitroprusside. And then the last paper is just about these guys who say, here's the way that you don't miss these things, because we're a bunch of cardiothoracic surgeons in Yale. People refer their cases to us all the time, so here's the mistakes that we see. First of all, You got to remember this age range. 19 to 74 is what they said. They said the consequences are serious if you miss it. I'll write that one down. That's important. The diagnosis won't be made unless you consider it. There's that anchoring bias again. Typical textbook findings are often absent. A negative D-dimer would be very uncommon in aortic dissection, and liberal use of imaging is advised with high-quality readings. Apple pie and motherhood. Okay, any questions, comments, disagreements? Have you seen a dissection recently? No? You saw it, you just didn't diagnose it.